Now that we've learned about some of the key mechanisms underlying the breakdown of immune tolerance, we're ready to start discussing each of the types of hypersensitivity reactions and the mechanisms that drive them. This mini lecture will focus on type 1 hypersensitivity. So again, there are 4 types of hypersensitivity reactions. We're going to focus here on type 1. This is mediated by IgE, and IgE specifically induces the activation of mast cells and the generation of allergic reactions. So let's talk a little bit about how we get sensitized to generate these types of hypersensitivity reactions. First, many of us are exposed to inert molecules that are usually not immunogenic, but under certain genetic background susceptibilities, they may induce an immune response, and these are called allergens. Allergens include things like pollen and dander and mold and grasses and things that you inhale. Also things that are injected, such as a bee that injects you with insect venom. There are certain foods that are allergens that are ingested, such as nuts and shellfish. And lastly, there are certain allergens that contact the skin, such as latex. And those are a little complicated because some of those can induce type 1 hypersensitivity reactions. Some of those can induce type 4 hypersensitivity reactions, which we'll talk about in a later lecture. When these allergens enter into your body under certain conditions, you can generate immune responses. Here we have an activated dendritic cell presenting allergen peptides to this T cell. And if this happens in the presence of IL-4, this T cell can become activated to become a Th2 cell. And these Th2 cells then are the drivers of the allergic response. And so this all occurs during that first sensitizing exposure to an allergen. These Th2 T cells in turn produce a lot of IL-4 themselves, and that IL-4 induces class switching of B cells and the induction of plasma cells that make lots and lots of IgE, now specific for that allergen. So again, IL-4 is important for B cell class switch to IgE. And this IgE can then bind to the surface of mast cells that express the Fc epsilon receptor. And these mast cells now are effectively armed. They're coated with IgE molecules specific for an allergen, and if they ever see that allergen again, they're going to be able to induce activation of that mast cell. So that's what happens on a second exposure. I should also mention that Th2 cells make a lot of other cytokines, such as interleukin-5, and interleukin-5 can activate eosinophils, and eosinophils are actually also an important contributor to the allergic response. And in fact, there are some allergic responses that are IgE independent, and it's thought that they're driven largely by this axis, these Th2 cells that activate the eosinophil response. Now, let's say months later, you are exposed to this allergen again, towards which you've made an IgE response. This allergen is now able to cross-link antibodies on the surface of this mast cell. And when that happens, it induces the activation of this mast cell, which promptly degranulates. And these granules are full of little goodies, and particularly histamines and leukotrienes, as well as a number of proteases that enhance inflammation and tissue invasion. So let's talk about the role of histamine. Histamine primarily mediates its role during what we would call the early phase allergic reaction. This happens within minutes after exposure to an allergen, or a second exposure to an allergen, I should say. And histamine, one of its key functions is to induce vasodilation. And when it induces vasodilation, this allows fluid and cells to escape into tissues. And this is what is behind the development of edema and urticaria or hives, and the development of the symptoms of allergic rhinitis. Histamine is also really important because it induces bronchoconstriction. And so here we have a bronchial airway, and the smooth muscles have now constricted because of the action of histamine, and this is what is behind the asthmatic reaction. Sometimes this early phase allergic reaction is referred to as immediate hypersensitivity. So if you ever see that phrase, they're referring to a type 1 hypersensitivity reaction. You will also often observe, not always, but often observe a late phase allergic reaction. And this can occur 8 to 12 hours after initial exposure to the allergen. And this late phase reaction is mediated primarily by leukotrienes and cytokines. So cytokines such as interleukin-4 and interleukin-5 and even tumor necrosis factor can be produced by mast cells after they have been activated. And these cytokines can then induce activation and recruitment of Th2 cells, basophils, eosinophils, and neutrophils. And this dramatically enhances the inflammatory response within the tissue and prolongs it quite a bit. The other product made by these mast cells after they're activated is leukotrienes. Leukotrienes are vasoactive lipids. They are derived from arachidonic acid. And like histamines, they induce vasodilation, they induce bronchoconstriction, and they also induce the activation of many of these cell types. And it's important because allergic symptoms can often resolve and then worsen many hours later after exposure. And so patients that might suffer an anaphylactic reaction might feel like they're getting better and then all of a sudden take a turn for the worse. And this is due to the late phase allergic reaction. So what is anaphylaxis? Well, anaphylaxis typically occurs when you get a high dose of allergens, and usually these are to allergens that are either injected, such as venoms, or ingested, such as certain foods like peanuts and shellfish and so forth. These allergens can, because of that high dose, can induce systemic effects such as vasodilation and airway constriction, edema and hives, and gastrointestinal distress. This in turn can lead to a drop in blood pressure and poor organ perfusion and the onset of shock. And eventually, if untreated, can lead to organ failure and death. The nice thing about anaphylaxis is we do have an effective treatment. And so if you can get to these patients in time, epinephrine is a very effective treatment for reversing the effects of anaphylaxis. What are the treatments then of type 1 hypersensitivity? Let's go to the one I just mentioned, epinephrine. Epinephrine acts to increase vasoconstriction. It increases ventricular contraction and heart rate, and all of this leads to an increase in blood pressure and is the go-to treatment for anaphylaxis. And so an EpiPen, for example, can be carried by an individual that is susceptible to severe allergic reactions as a way to treat an anaphylactic response. Antihistamines are quite a common method of treating allergic reactions, and antihistamines can induce vasoconstriction and bronchodilation. Albuterol is a common method for treating certain types of asthmatic reactions, and that is because albuterol also induces bronchodilation. It also induces or inhibits mast cell activation. And sometimes albuterol is referred to as a rescue inhaler, and it's a beta-2 adrenergic receptor agonist. And lastly, corticosteroids are a non-specific form of immunosuppression, but can be used for certain allergic reactions, including allergic rhinitis. And there are certain nasal sprays that can be used for people that have consistent or severe allergic reactions in that setting. Okay, so here are some of the key topics we discussed in this short mini video or mini lecture. The questions for the readiness assurance test for the TBL will all be drawn directly from this video and the tolerance video preceding it.